So good morning, everyone. Well, I'll talk about the current situation of HPV vaccination programs in Brazil. So just a brief introduction about the burden of disease in terms of cervical cancer, it has caused over 66,000 deaths in 2018. In 2020, we expect over 16,000 cases. It's the third most common cancer site in Brazil and the fourth cause of death by cancer in women. And across the different regions, what we see is an increase in cervical cancer incidence in the northern region, and it's relatively stable on the rest of the country. And this map also shows the higher incidence of HPV in the northern and northeastern region of cervical cancer, which thus coincides with the HPV prevalence data that we have from our nationwide prevalence survey. This study was done prior to our to the introduction of the HPV vaccines in Brazil, to have a baseline and to allow for an impact evaluation of our HPV vaccination introduction. And we have a plan. It is planned to have a new round of evaluation next year. So it was done in every Brazilian capital and the federal district, involving sexually active boys and girls aged 16 to 25 years old, in over 100 basic healthcare units. And what we do see is a high prevalence across the entire country, but higher in the northeastern and the northern region. So this is the northeastern and the north region of the country, which coincides with what is observed in terms of cervical cancer. Well, so the overall HPV prevalence was around 50%. The high risk HPV was above 30%, and multiple infections was also around 30% in the country. So, how was the HPV vaccine introduced in Brazil? We started vaccination in 2014 for girls 11 to 13 years old, and with an extended age range for female indigenous people. Our initial introduction was done in a school-based vaccination campaign. So we achieved the first dose vaccination coverage of 85%, with over 4 million doses given in 4 months. So in the second semester of 2013, during the administration of the second dose, we had an outbreak of immunization stress-related response in the southeastern of the country, in which 13 girls presented with neurological symptoms. They were thoroughly investigated, and despite the conclusion of having been an immunization stress-related response, it had broad media coverage. Also, during the second dose was no longer administered in the school, so we believe that both factors led to a lower coverage in the second campaign, which reached only 60%. In the following years, the age range was extended for girls, also extended for HIV girls living with HIV. In 2016, the age range was further extended, and in 2017, we started vaccinating boys 11 to 14 years old, and also other immunosuppressed individuals such as solid organ transplantation, hematopoietic stem cell transplantation, and oncological patients. Our vaccination coverage, so this is the cumulative vaccination coverage for girls 9 to 15 years old with 1 and 2 doses. And the different columns reflect different states in the country. We can see that only 3 countries have reached the 80% vaccination coverage goal for the first dose. And no no state has reached the 80% goal for the second dose. And we have a high variation of the vaccination coverage in different states. In terms of boys, our vaccination coverage are even lower. The highest is in the state of Paraná, which has reached 60.57% for the first dose and 44.86% for the second dose. And the overall country's coverage for boys is 45% for the first dose and 30.9% for the second dose. Although and when we see the vaccination coverage per age, it does increase with age, reflecting the fact that the boys and girls, they have a range of a large period of time in which they can get vaccination during their life. So and this is the cumulative vaccination coverage, and it does reach 100% in girls 14 years old, but it only for the first dose. The second dose, we do not reach the 80% vaccination goal. And now again for boys, I see the similar phenomenon, but still not quite at our goal. Now, in terms of COVID, our first case was confirmed in 26th of February. Since then, we've had over 5 million cases and 160,000 deaths. Around in the beginning of March, we saw, and in April, we saw a sharp increase in social distancing as a reflect of the social distance interventions that were ruled out over the country. Each state and even each city has issued its own recommendations. It was not a nationwide, even though it was quite, the behavior was, in terms of social isolation, was quite similar across every state. We saw a sharp increase in the percentage of people staying at home at the end of March and beginning of April, and it has been decreasing steadily across the country since then. How does it reflect in our vaccination programs? For several of our vaccines, when comparing 2020 with our historical vaccination data from 2015 to 2019, we see a decrease in the months of February, March, and April, which does coincide with the moment of higher social isolation in the country, but also from the 23rd of March to the 16th of April, we had a brief interruption of our immunization activities due to minimize crowding during the influenza vaccination campaign for the elderly people. So in order to protect the elderly, during the stage of the influenza vaccination campaign in which we were vaccinating them, we had a brief interruption of our regular vaccination activities, and we can see the reflect of that in a drop in vaccination doses administered. This also happened for HPV vaccine, so a sharp decrease in doses administered in March, April, and May, but it seems to have recovered from June and afterwards. And so the general, from January to August 2019, when compared to January to August 2020 to 2019, we see a 2.63% decrease in vaccine doses administered to women. For men, the impact seems to have been higher, and it has not yet fully recovered to the baseline. So we've seen a drop of 25.7% in the total number of vaccine doses administered from January to August in January to August 2020 when compared to January to August 2019. So how to improve our HPV vaccination coverage? We have already done a multi-vaccination campaign in October this year. The data from this campaign has not been presented since we have some delay between the dose registration in the sites and it finally being compiled and brought to our national databases. But we do believe it might have had some impact in recovering HPV vaccination coverage. Also, we understand that the most effective strategies is the involvement of school, not only in school-based vaccination, but also through health education and to help verify vaccination cards. Also, we have a really close relationship with the scientific societies to help promote our vaccination campaigns, not only the immunization, pediatrics and infectious disease societies, but also the cancer society when talking about the HPV vaccine. And we do understand that it's paramount to improve access to healthcare centers since it was the barriers to access was the most important factor involving in when parents responded to why their children had not been vaccinated. So offering alternative working hours and is important so that people can have better access to healthcare centers. And also from the beginning, aside from the brief interruption during the influenza vaccination campaign, we have provided guidance on how to maintain the immunization programs. And we have kept most of our campaigns, our measles campaign and the influenza campaign has been maintained, although we did see lower coverage than expected. And we have also recently issued guidance on how to recover delayed vaccination cards, talking about the minimum and maximum intervals and how to quickly catch up with the delayed vaccination cards.